We are proud to have today three speakers. The first part will be on clinical trials and some of the journey of Professor Nader Shaikh as he explains the methods that he has been using for his research. And then the second part will be on vaccines with Dr. Steve Pelton from Boston and Dr. Pete Morris from Australia. We'll start with Dr. Sheikh. He is a pediatrician in the Division of General Academic Pediatrics at the Children's Hospital of Pittsburgh, and he specializes in clinical trials. So, our ask for today is that he describes some of his methods, which we believe will be very helpful for our mentees, who will also be watching the recording as we post it on the website. Thank you so much for agreeing to talk today, Nader, and I hope that you can explain more of your background.
Okay, thanks. Is my voice coming through and everything okay? Okay. Yeah, I've been in Pittsburgh for 20 some years and I went there as a fellow and uh there was this guy called Jack Paradise. He basically taught all of us there how to do clinical trials. He would have been 100 about last week. So he started doing a lot of clinical trials way back when. Uh, in the 80s, I believe. And so Pittsburgh has been a place where lots of clinical trials have been done for tonsillectomy and tubes and adenoidectomy and OME and all sorts of things. And then so it sort of was obligatory to do some kind of otitis media clinical trial, something. So that was how I ended up doing clinical trials more or less for a portion of that time. And then the clinical trials that I've been involved with were uh, placebo versus antibiotics was the first one. That was in 2011, published in 2011. And then we had 5 versus 10 days of antibiotics. And then we had tympanostomy tubes. And we're working on some other ones now. And I also do sinusitis clinical. I did one big sinusitis clinical trial, and I do work on UTIs a lot, urinary tract infections. So that's my story. There's a lot of other people on this call that may know more about clinical trials than I do, but I just thought I would share some basic things about clinical trials and just keep it interactive. Hopefully, we won't all fall asleep. Um, so, is this working? Okay. So we are going to talk about first the definition of a clinical trial. Um, so there's an NIH definition, which is very, very specific. If you are planning to submit a clinical trial to the NIH, there's a sort of a calculator that does this for you. So you should go to this website down here and answer these four questions. Are there humans involved? Are they prospectively assigned to an intervention? Is the study going to evaluate some effect of the intervention, and is it being related to some outcome? So it's more broad than you think. If you like hand in a piece of paper to a bunch of people and this could affect their behavior or outcomes, that's a clinical trial. If it's low risk, it doesn't really make it not a clinical trial. If it's one group, it doesn't make it a clinical trial per this NIH definition. Most people, when they talk about clinical trials, they mean we're going to compare drug A versus B. That's a specific type of clinical trial, but a clinical trial has a broader definition, which you could figure out by going to this website. Um, there's some good books about clinical trials. So uh, the first one is by Tom Newman. He's at San Francisco. He's written a very good introductory book. So if you're a junior person and you want to do clinical trials, you could read this book. It's very, very easy to read, and it tells you every single step, like how do you write your question, what do you do about the IRB, how do you calculate your sample size, et cetera, et cetera. And it's very, very accessible. And another book that's good is by Sackett. He's the guy who basically started evidence-based medicine at McMaster, and he has a very good book that has more detail and is more technical. You need to know something before you write a clinical trial because clinical trials are expensive. So nobody's going to give you a few $1 million if you just write on a piece of paper, I'm going to and compare A versus B. You have to really know what you're talking about. And even if you've taken epidemiology or evidence-based medicine in medical school or some kind of school, that's usually not enough because there's lots of ins and outs that you only learn by messing it up a lot of times. So you should be seeking somebody's help if you haven't done it before. Also, it's important to think about bias in clinical trials before you start, not after it's done. So there's a whole bunch of stuff on bias and how you assess it. Um, these are going in a weird order. I'm already on slide 5. Okay, fine. So we'll talk a little bit about bias a little bit later. But I wanted to put up this slide for us to show the steps of the clinical trial according to this article here. Um, so on the left side, you can see collaborate, which is what I was talking about. You sort of have to collaborate with other people. This is a good thing because you need to bounce your ideas off of other people. And you need to go back and forth. So iterate and refine on the right. You sort of come up with some idea. It's not good. You sort of do some steps, then you go back to the beginning and you do it over and over again until you have something that makes sense and then it's sort of like good to go. And so we're going to talk about each of these steps. And feel free to stop me anytime. Um, yeah, I think this is not the right set of slides. Hold on one second. So to the first step in that diagram was prior knowledge. So this is an important thing. It's not just something they put on the picture there. It's best to do a question where you sort of have an area of need that's annoying you. So um, if you're a clinician, you have an advantage because you go to the clinic. Stuff that annoy you, usually that's what makes the best clinical trial. Like you're treating patient after patient, and you're like, why am I doing this? Or why are we not doing it this way versus that way? Those are good clinical trials. For example, in sinusitis is a very annoying disease for pediatricians who practice. So you go in a room, somebody has a runny nose, you have no clue what they have, and you have to guess whether they have sinusitis or not. So that's a clinical problem that I had when I was young. And I was thinking, like, how do we solve this problem? And uh, that sort of makes a better clinical trial if there's an area you're trying to answer rather than starting the other way around. It's like, let's find two things to compare. Um, so after you sort of have your clinical question or you ask a clinician, if you're not a clinician, you sort of have to have a team that has somebody who deals with the real world or some kind of patients because at the end of the story, you want to benefit some patients. And then you sort of do a literature review. What trials exist? Um, it's very helpful to be systematic, not just for, first of all, you learn all the different ways you could possibly do this trial, but also when you apply for a grant, if you have a systematic background section that shows you that you've looked at every single thing and you could see where the holes are. If you just look at 3 articles and then you don't know what wasn't done exactly right or differently, or what are the gaps in the literature. If you're systematic, you can figure that out. And then you could sort of determine how your trial will be different to fill these gaps. So then after you have your idea, there's some general ideas, general concepts. If you can either be broad or narrow, that's like everything else in life. If you're too broad, your thing is going to have a huge impact, but you might not be able to do it, or it might be too broad and it won't mean anything. And if you're very narrow, or many people might have done it, if it's a very broad question everybody's thought of, then you have to go more narrow. But then maybe people don't care about the more narrow version. Um, so you have to go back and forth trying to figure out how broad do you want it to go. And you have to be able to have a good reasoning for each of these steps. You don't just pick one out of the blue. You have to figure out why you want to go broad or what are the pros and cons. And we talked about a team. A statistician is very important, not just at the last minute to get a sample size estimate, but the statistician thinks in a different way. And if you have one that you can talk to, which is not easy to find, then you have an advantage. A lot of people think they have to have some majorly original idea, and that's not required. Like, sure, you get points on innovation, but uh, it's not the main focus of a clinical trial. Is usually to fill a gap in the literature, and that's what you're trying to do. And the other stuff is just extra. So don't try to be too original and kill the study by being too original. So try to just do what's needed. And people, the reviewers understand that you're not original because you're trying to answer this question, which everybody has. Um, if you pick an esoteric condition, you're going to be having very few patients or take 100 years to finish your study. So common problems are easier to study. Um, Access to patients is a very complicated thing. So again, it's sort of you need to be involved with some people who are on the ground and like seeing patients on a daily basis and know what the landscape is and where can you fit in. So after you sort of think of your idea, also think like, let's say you're thinking of this idea, what would happen if you did that idea? Would anybody care about your idea, or you would just spend 5 years doing it and write a small paper and nobody would ever read it? So you have to sort of think about what is the real reason to do this study. And then this is a mnemonic you've probably all heard about, but it's very, very important. I think this is the most important thing about a clinical trial design is this silly little mnemonic, which they teach you in all sorts of places. But this is probably the hardest part of a clinical trial to decide because, again, for each of these, you have to be exactly sure why you're picking each of these and have a reason in your grant. Like, I'm picking a population of 2 to 12 or 1 to 6 or less than 1 month of age. And you have to have a reason because the reviewers will, as soon as the first line of your thing, you're like, why did you have to pick less than 3? Why didn't you pick less than 4? So I had this just happen recently. I'm like, really? So you have to have a good reason to answer them. Otherwise, they're like they will subtract points for any little thing. So if you have not explained why you have a certain population, you're going to be in trouble. And we're going to talk about each of these in more detail. Then you have the intervention, comparator, outcome, timing, and setting. But this is very, very important. So population, one important thing in that is the definition of disease. Like everybody says AOM, but what do you mean by AOM or acute otitis media or otitis media with effusion? There's like a million ways to define that. Are you going to use the doctor's diagnosis? Are you going to take a picture? Are you going to put a needle in the eardrum? Are you going to, what are you doing? So what is the definition? Does it have to be red? All of these things matter a lot because at the end of the trial, when you finish, somebody's going to write a letter and say their definition of disease was no good because it was too mild. It was very stringent, and that doesn't apply to the real world. It was very mild, and who knows if they actually had otitis media. So both of these are very common critiques of trials that are out there that are just we don't know if they had otitis media because the diagnosis was too loose, or in our case, these people are asking too much for the diagnostician and they had to be this and that, and that's too stringent, and these results do not apply to the real world. So that's a very important thing to define your disease carefully. And I talked a little bit about the age, but that's also important. So these are things that you should think of. This list is not comprehensive, so there's many things to think about under the P or population. Spectrum of disease, again, is very, very important. That relates to the definition, but this is something drug companies often use to their advantage. Like they want to show that the drug works or doesn't work. They enroll very severe patients or mild patients. So you have to understand what they're doing, and you have to understand what you're doing as a clinical trial person. Like, why are you like only including mild or severe? Why is it not general? Why don't you just take everybody who walks in? Or so all of these have to be explained, and it's not easy figuring out what you should do. Like if you're doing a proof of concept study, maybe you want to not just take the mild kids because you're trying to show something as a principle. But if you're trying to make something generalizable, then maybe you should take everybody. So there's pragmatic studies and very, very controlled randomized trials, which are very tight and everything is set in advance, like protocolized. So there's you have to decide which way you want to go. And then the part of the population is, can they have comorbidities, or can there be anything else wrong with them? Who are you going to include or exclude? Um, these are parts of the things you have to think about. Any questions so far? We're going to be done very soon. Uh, so the intervention and comparator, your INC. So again, lots of stuff to think about. How long are you going to give your intervention? Is it going to be 5 days or 7 days or 10 days, or like we did a trial for 10 versus 5, and people were saying, why didn't you do 7? So so there's all sorts of like little things you have to think about. Um, Timing of the intervention, like when are you going to give it exactly? Are you going to give the first dose when they're in the office so you can observe it being given or not? Are there co-interventions allowed? Or if you allow them to use a lot of pain medicine, maybe that will mask your outcome, but that's what people do. So why shouldn't you mask it? The dose of the medicine is important because you're going to report diarrhea. If you give a huge dose, everybody's going to have diarrhea. If you give a tiny dose, it might not work. Um, Also, in otitis media, we don't have a lot of data on organisms that are floating out there, and because tympanocentesis studies are not so common anymore. So we use medicines that we think work for most people, but we don't really know that exactly because there's so few tympanocentesis studies. So we might not need to use high dose amoxiclav for every person. So we might be overdoing it in some cases. Um, so another important thing about your comparator is a lot of people say, I'm going to do it compared with usual care. So usual care is very, very vague. It could be anything. It could be you could be getting a very, very good usual care or a very bad usual care or like a negative usual care. So you have to be able to measure whatever you say is usual care. It has to be something that can be looked at and people say, oh, okay, that's usual care. I can repeat that. I know what it is. But if you just let anything happen that can happen, your study will be sort of limited to like your settings type of usual care as a comparator. It will mean less and it will be less generalizable. Um, okay, I think that's good enough for this one. Okay, outcome is probably the most important thing. This is sort of what I do when I'm trying to think of a clinical trial. I imagine I'm a parent or a patient, and I sort of list stuff that's bad and good that I want. Like I have this problem, they're going to give me something, like some kind of medicine to make it better. What would I want from this? What are the good things that could happen from this medicine, and what are the bad things? Like what outcome do I want to most improve? Do I want my pain to go away, or do I want to sleep better, or what is it, or do I want to? Yeah, so you have to list them all. I list them all. It doesn't matter if you can. So just to think about it conceptually, just list the stuff that is relevant for this disease and that this medicine might be able to treat. Um, and I put them in order, like what's the most important thing about this disease that this medicine should get rid of. Um, Realistically, I mean, some things are the medicine is not going to fix, so you have to sort of think of things that this medicine, like conceptually, it might treat this. So then we want to measure it. And then you have to decide how is it going to be measured. Like if the most important outcome is pain, let's say, like you have otitis media, the kids are in pain, they're screaming their heads off, and they can't talk. So most kids with otitis media are under 3, so they don't tell you much. And so if pain is the most important outcome, then how do you measure it? If you can't really measure it, then you have treatment A, treatment B, and you have some non-measuring thing in the middle. You're like, just come to the office. I'll look at you and see if you're in pain, and then go home. There's an example of this kind of trial in the literature that's in the Cochrane Review, one of the 13 trials available. That's one of them. The patient came into the doctor. They're like, "You're fine. Go home." And then that night, the kid might be screaming or not happy, or maybe they're happy. In other ways, the parent like says something or So that you have to sort of see, is this a measurement thing that can be trusted? Like you have to have a ruler or of some sort. Otherwise, why compare A and B? There's no way you can conclude anything. So it's going to be a huge waste of time. And I would probably just not do that trial. Just if there's something, if more important outcomes cannot be measured, you should just do something else. Uh, because it's just not very useful. A lot of people, when their outcome is difficult to measure, they go down the list. So they're like, we can't measure pain, but we can measure temperature. So let's measure temperature. It was at 37.5 in one group, 37.7 in the other group, and we make a big deal out of that. Or there's surrogate outcomes are things that are supposedly related to your primary outcome and are easy to measure. So usually reviewers don't like that for good reason because it's sort of, we don't really know what that means. So I would try to stay with the important outcomes, even though they're hard to measure. And I forget which statistician said that. I think it was Tukey. He said like it's better to measure something important and measure it roughly but to do a good job than to not try to understand it at all. So it's okay if you can't measure something perfectly. I'm not saying it has to be perfect, but you have to have some kind of tool that's can be reproduced and somebody's looked at. So another thing you have to think about with outcomes is composite outcomes. So composite outcomes have pros and cons. Some trials are never possible unless you combine things like cardiovascular trials. They usually combine a few things because each outcome is so rare and they will never be able to power a trial large enough to answer any questions. But they do a lot of work showing that way to compose that the way to put these outcomes together is meaningful. Like if you have some things you're adding that some of them are good and some of them are bad, or some of them are not exactly, you don't know what they're doing, then that's not a good idea. So composite outcomes have a place, but it's you have to have background information that explains to the reviewers like why are you adding these two things in this way? What's the weight of the first one versus the second one? Aren't they different? They're going to ask all sorts of questions. Any questions? Or is something's in the chat going on? If something is happening in the chat, I'm not seeing it. Am I
Yeah,
supposed to be reading that?
Oh,
I'll read
sorry,
it
that's
off.
me.
Oh, this. Yeah. Okay. Go ahead,
Oh, hi,
Julian.
Yeah.
Julian.
Hi,
Hey,
Nader.
hi.
I've been talking to Charles a lot. What are your tricks for doing trials like this in a primary care setting? Because thinking about all the steps you have to do in terms of consenting and getting families to kind of understand the different treatments that could happen and
Yeah.
all of the outcome measures, like how do we do that efficiently?
Yeah, so we don't really, yeah, so you have to sort of um, be in that primary care setting, sort of, and see patients. Usually, you have to, or ask somebody who does this and works in a primary care settings. And it's hard to do research in primary care. Like if you try to do it in private practice, the doctors have 3 minutes when they see a patient. The patient walks in, they don't sit down in the waiting room. They just bring them back. They look at them and they send them away. Like in 2 minutes, they're out of there. Like the good private practices. So they're like, "Why you want me to like swab their nose?" Like, no way, that was gonna take 45 seconds. I don't have that much time. So, but over time, we've sort of trained our private practice doctors. Some places have practice-based research networks, like you guys have at Duke, and other places have really efficient ones. And so they've been doing this for a long time. They've like taught the doctors that if they do this, they get something at the end themselves. They can be involved in the research. They can be planning it from the beginning. They can be on it, the paper at the end. They can get reimbursed for it. That's one of the things that the private practice doctors like reimbursement. So we do reimburse the doctors. Otherwise, they don't have time. It's just not something that's going to happen. And then the other academic practices, they're more flexible because patients are usually sitting there for like 2 hours before they're seen. So we have a lot of time for those. But I mean, also in our practice, the patients are like when you go have a baby, everybody's approached for research in a maternity ward, it seems like. So the same thing is happening in our clinic. Every time somebody comes in, they're expecting to be randomized to something or another. So they're sort of like whatever, they just get it now. So other tricks is yeah, looking for places that have if you're trying to do a primary care study, you look for places that have done this before and have a network. If you're looking for a large number of patients, you need networks, and there are places that have networks, and you can look them up in the PCORI website or there's a PBRN listings and stuff like that. I would look for that. Did I answer the question?
Yes, that's actually really helpful. And I'll probably bug you more later. Because, like I said, I've been
Okay.
talking to Charles Woods
Okay.
a lot about the study you guys are talking about. So thank you.
Okay. Yeah. Um, so yeah, the primary outcome is the one you choose. You have to pick a primary outcome because you power your study based on your primary outcome. We've picked co-primary outcomes before. It was very difficult to deal with because one of them turned out to be positive, the other one was negative, and then we're like, we have two primary outcomes. One of them worked, one of them didn't work, and you have to explain that to readers. It's just absolute disaster. So it's probably just better to just pick one outcome. I think is easier, at least on the brain. Um, yeah, your outcome should be replicable, like I said, and valid. So if you pick something that's just you make up a little thing on questionnaire and you give that to parents, the reviewers are not going to buy that. You have to use a validated scale so people know like what is this that's being measured. Like, is this questionnaire measuring something that I care about? One of the examples is early on we wanted to do a trial of placebo versus antibiotics, and we didn't have any way to measure anything because the kids were miserable, and we wanted to see if the kids on placebo were less miserable or more miserable. And we developed a scale, and it took probably 5, 6 years to develop it. And we had to give it to patients with ear infections and otitis media with diffusion and colds and healthy people, and then look at their scores and show this and that. And it's very, very complicated. I would not recommend it, but if you can find something that's validated, then you're set. And there are some stuff like Dr. Rosenfeld developed a OM6, so that's used a lot for OME type of research, looking at quality of life. There's more and more of these scales. There's a parent, a caregiver quality of life scale. There's a bunch of scales that are there. If you use those, then people say, okay, at least I know where this is coming from. Other people have looked at it. I see the score, and sick people and normal people are different. Um, I used to think these are sort of a formality just to call it a validated scale, but it's sort of like the way the scale is built is actually does matter because in our early our trials we used the earlier version of the SOS that we just like it took us 5 years, but we weren't experts in developing scales, and this is a whole field. Like people have like written hundreds of books on this, and we did not read these books. Um, so we consulted with some people, but anyway, over 20 years, we refined this measure, and I think it's working better now because it's just there was problems with it that we solved over time. So the issue of a scale is sort of also important. Like if you're measuring something vague, you sort of have to know more about it. If it's something simple you're measuring, then you don't need to think it so much. But if it's a vague thing, you have to sort of spend a lot of time like, what am I actually measuring, or is this just noise? Because there's a lot of noise in otitis media symptom research, at least. Like every parent is different. Some parents don't worry about certain things, and other parents are like a little sneezing is like a major problem. And there's variability in between the kids, and also the scale has a lot of noise inherently in it because they're like touching their ear, like or like are they in pain or they're crying for some reason? Are they like having an ear problem? So this is very very gray area. So so then the last two things, the T and the S on the PCOTS. Yeah, again, timing of the intervention. How long are you going to follow them? If you don't follow them long enough, you don't see like the full effect of it. Um, you have to decide whether you want to go after inpatients or outpatients, and that's also going back to the population. And if you're going to go in referral clinics or primary care. Um, yeah, there's nothing wrong with the referral clinic except the patients might have some selection bias. And the primary care is the other side. I mean, that's where the patients are coming, so there's less of that, but depends on your question. It might be more appropriate to go to referral clinic for some things. Okay, so then you have your question. You're done with your ideas phase. Now you have this idea, like how will the study be designed? And this is not this talk. I don't have enough time to talk about all these things, and I don't know all these things. But one big decision is whether you're going to randomize or not. Some things you cannot randomize. So if you're not doing randomization, you can do a large, good observational study. Um, we're not talking about that today, but those can be effective if you plan it properly and you have people who know how to do that. When you're trying to randomize, you can randomize people or clusters. So a cluster is like a classroom. This classroom is going to get this, the other classroom is going to get that. These are becoming more common. Cluster randomized trials are becoming popular, actually. Not popular, but there's a lot of people who are applying for grants are putting this in their design. And there are pros and cons of that. I think I have a slide on that, so maybe we'll talk about it later. But the types of trials, usual types of trials are parallel trials. Those are the most common one. The picture on the top, you just have one green drug, one reddish drug, and you compare them. You give everybody either A or B, and they're usually blinded. You follow them for an amount of time, and that's the normal clinical trial everybody thinks about. So that's a parallel trial. And then crossover is you give A and to one people, and then they wash out, and then they get B, and then the same thing, the B versus A, and then they get A. Um, there's factorial trial. If you think of a 2 by 2 table with A and B, they can get A plus B, or neither, or just A. So you can have a combination. And that has the advantage that you don't have to do two different clinical trials to study two factors. You can actually get the answer for both by increasing your power, by increasing your sample size a little bit, but not the same as doubling. Like if you had to study these two things separately, you would have to do two separate trials. So factorial trials are a cool way to answer multiple questions. Like, do the kids do better with antibiotics? And what about if steroids or some whatever you're trying to study? Like, do they get both, or just one is better than the other? Or you can answer all those questions with a factorial trial. Um, Adaptive trials are very, very interesting type of trials where you switch things up in the middle of the study. So usually in a normal parallel trial or all of these trials, you're very, very strict. You're blinded. You don't know what's going on. You don't look. There's one maybe interim calculation where you find out if people are doing worse in one group. But in an adaptive trial, there's many different types. This is way beyond the scope of this trial. But if you're interested in doing innovative clinical trial design, that's a very cool area that's getting to be used a lot in the ICU population. And usually the way it works is they have like 10 medicines that patients can get in the ICU for pneumonia. And out of these 10 medicines, in the background, this thing is calculating uh, which medicines are working. Out of the 10, three of them didn't work. They get rid of the three early on. Like as soon as they figure out these three are much worse, but and this is not by chance. Those three fall out, and then seven remain, and then more drop out. They come in and out. You can add more new medicines. So and it's all done with the background. There's no person doing anything. So that's one type. Then there's a biomarker adaptive trial. So that's another whole thing. I think just skip this for now. Um, yeah, cluster randomized trial. You in this picture of England here, you have a bunch of people. They get control or treatment. That's the usual trial. And in the cluster trial, you do certain types of people. Classroom example is easier. The classroom A gets this treatment. Classroom B gets another treatment. Um, so the pros is you might not have to consent patients if you do a cluster randomized trial, and you say these two are standard of care. We're just going to have this clinic do this clinic do this. Then there's no need for consent if the doctors think this is standard of care. But you still are randomizing the clinic, so it's a little bit weird to tell this doctor you can only do A. But that's how it works. And instead of patient level data, you have patient level data, but you also have this cluster. So your number of clusters has to be high. Otherwise, it's not going to work. It's sort of like a meta-analysis. If you have three studies in there, it's not going to tell you much more than if you just go read those three studies. But so you can't do cluster randomized trials unless you have a large number of clusters. So then it becomes a headache to get all these clusters to work. So it's not a shortcut usually to do it. It's actually has a larger sample size and it's very complicated to. Um, it's not very complicated, but anyway, you have to deal with other problems other than just randomizing people, which is easy to understand. Um, and then there's also issue of confounding, like classroom A gets one classroom gets treatment A versus another one gets B. So the classrooms are similar in some ways. Like classroom A, every kid has the same teacher, and they're probably all from the same socioeconomic group, and the other one is in another school. They're different. So there's many things that are going together, and that's going to cause confusion. And that's why you need a large number of clusters. And there's different types of cluster randomized trials, just like regular trials. But one that's becoming popular, or I see in grant applications, is this stepped wedge design, where like one clinic starts 1 month later than the other. So then you have different times of entry, and you can see if your treatment is making a difference in those times. I've never done one of those, but it sort of comes up a lot for some reason. Um, Then there's a phases of clinical trial. I'm not going to really go into this, but this is everywhere if you want to find out. But I've mostly had to deal with phase 3 or 4 clinical trials. So we have a medicine. You want to see if something about it works better than the other medicine after it's approved. Um, any questions about it so far? So then there's this slide is a little bit of a headache, but some people, this is another issue that you have to sort of think about. That's why I'm saying you should have a statistician because normal people don't think about these things. But there's 3 different main things, choices that you have. Like the first one is non-inferiority, and the English version is you're saying A as is at least as good as B. So if that's your question, pick that one. Superiority, A is better than B. So if that's what you're clinically, like which one is the question? Like if you have the drug that works, then maybe you don't need to say that my drug is better. You just say my drug is as good as this good drug that we have. Then you don't need superiority. And superiority is like A versus B is smaller than A. The first one, non-inferiority, is larger, so the sample size is usually smaller. So you sort of have to pick one with a reason, and it will affect your sample size. And equivalence is somewhere in between, like A over B is 1. So the two are the same, and you have a margin that they are by no more than 20% or 3 points or 1 day, or whatever it is. So that's the equivalence trial. And the equivalence and non-inferiority are close, and you can Google the difference and get confused. Um, But usually I wouldn't try to overthink it. Like, what is your question? Are you trying to show A is better than B or is the same? And then go based on that. Um, yeah, places you can go for funding for large clinical trials. You either have to go to the NIH or PCORI. PCORI is a new thing, which apparently the government hasn't heard of yet, at least the Republicans. Uh, so it's not shut down yet, and it's stands for Patient-Centered Outcome Research, something like this, Institute. And they fund a very specific type of clinical trial. So NIH funds anything. Uh, so you can apply for a parent R01, which is your ideas. Like, I want to compare this versus this. And nobody's ever thought of this, or this has been done many times before. But whatever it is, if you can convince the reviewers, that's okay with the NIH. But PCORI doesn't do it that way. PCORI only wants things that are actually being used in the real world. Both A and B have to be very commonly used, and there shouldn't be trials comparing them. So this very specific thing. Otherwise, they're not interested because that's where they get their money from the insurance. And so the insurance person wants to know, like, which one should I pay for? and they sort of every person pays $1 or $2 to this go in here, and this is what they're supposed to do. So they don't accept anything that doesn't have to do with that. Yeah, this is the thing about bias I was talking about. There's a lot of data, like a lot of improvement in how bias is assessed in clinical trials. The Cochrane definition of bias is like a trial is not biased just because you don't like how it was written. It has to be systematically away from the truth. It has to go in a certain direction away. So it's a systematic error. That word systematic is important. Otherwise, if it's just sloppily done, that doesn't necessarily mean it's biased. It could have been sloppy in both directions. So how do you tell that there is bias in a study? So uh, you can use this tool called the Cochrane risk of bias tool. I think I have that somewhere. My gosh, I have a lot about bias. Um, yeah, so bias is there in every study. And as I said, it's not poor quality or imprecision, but it's systematic error. And there's many, many types of bias. There's actually like a whole dictionary of bias, like on the web somewhere, put it together by Canadians. But the main biases are these ones listed here. If you mess up your data, or if people find out what they're getting, especially the doctors, if the doctors know what the next patient is getting, that's called allocation problems. So if the doctors are always going to mess the trial up, if there's any possible way they can figure out what's being given, they're going to figure it out, and they're not going to put sick kids on placebo. So you cannot have them find out in any shape or form. So that's allocation concealment. Um, Blinding is sometimes possible, sometimes not. Sometimes it's not important. So it doesn't mean it's blinded. If it's not blinded, it doesn't mean it's biased. It's just maybe their outcome is mortality. It doesn't matter if you're blinded or not. Um, Attrition is a big deal. If you have lost a lot of patients, there's no percentage, but are they unequal in the two groups? Um, so this risk of bias tool that I was talking about rates these 5 things. So you should look at this before you design a trial. If your trial has a problem, these are gonna come up after your trial is done. So you should look at it before you start. And you can find a new version of this tool on this website. It has very, very, very detailed instructions of pages and pages long of how to do these 5 things. And these are the books that I was talking about. The last one we didn't talk about is the Cochrane Handbook, which has not directly relevant to designing a trial, but that's where you sort of assess a trial, and it's very helpful, I think, and it's free. So that's all I had.
Thank you. Are there questions from the audience? Go ahead, Peter.
Thanks, Nader. That was great. You mentioned in one of your slides about doing simulation of trials before you do them. Is that something you do in Pittsburgh?
No, we never were. We weren't that advanced. Uh, but yeah, simulations could be important. I've tried to do it before, but we didn't have a statistical partner. Like one of the questions I had is whether inclusion of lots of children with iffy diagnosis messes up your trial. Like, how do you simulate that to figure that out? Or so simulation can be helpful, but you really need somebody who can do it. And it seems like we didn't have anybody who could. Have you done it?
No, but I work with someone, Tom Snelling in Australia, who's really does it all the time now. He does
Oh,
really
really?
great trials. He's
Oh,
doing adaptive
oh, wow.
platform trials in pediatrics.
Oh, wow. That's awesome.
Yeah.
Yeah, I
The
find
other
those very
question I had
attractive. Mhm.
is because you're a big center and you've got a really great health economics group in Pittsburgh. Do you work with them?
Yeah, we did work with them a few times to try to do a cost effectiveness or economic analysis on the side of the trial. So you're doing a randomized prospective trial. You can collect that data prospectively as opposed to backwards, which doesn't work so well. So we could see like they went to the doctor, which type of doctor, how much did they cost for parking? So we asked all these questions. Did they have to arrange another daycare place. What was that about? And did they miss work? How many days? So every time they came in for visits, we collected that and then we gave it to the health economic person to analyze. And that could be an aim of your study.
I really appreciate this, Nader. I know of quite a few junior faculty who manifested their intention to start an RCT, but they don't have a fine-tuned hypothesis or research question yet. So it's very generous of you to share these nuggets of knowledge that are obviously hard-earned over the decades. So, and it's a perfect setup also for the next part of this webinar. So thank you.
Thank you. Thanks for inviting me.
All right, so we'll move on to Steve. You can go ahead and start sharing while I introduce you, Steve. Professor Stephen R. Pelton is from the Department of Pediatrics at Boston University School of Medicine in Massachusetts. He also serves as senior attending physician in pediatric infectious diseases at Boston Medical and is formerly the chief of its pediatric infectious diseases section. The goals of his research has been to reduce the burden of respiratory tract infection in children, and the focus includes evaluating new antimicrobials for experimental otitis media, including transtympanic gel formulations, the impact of pneumococcal vaccines on epidemiology of pneumococcal disease, on understanding the impact of PCV on nasopharyngeal carriage of strep pneumoniae, on identifying emerging serotypes of interest, and also identifying specifically serotype 3, escape host defense, and anti-capsular antibody. I think you should just go ahead and introduce your studies to us, Steve. I'll stop there, and please go ahead and give your talk. Thank you.
Thank you, Reggie, and Neda, thank you for a very interesting talk and update on the latest in clinical trials. So what I'm going to talk about, hopefully in the next 20 minutes, is does pneumococcal conjugate vaccine prevent acute otitis media? Before we start, we have to define or understand what the pneumococci are. And this is a picture of pneumococci, specifically stained to show their polysaccharide capsule. The polysaccharide capsule is a critical issue. One, it's a virulence factor. Two, it's the largest antigen displayed on the surface of the pneumococci, so it makes a very good vaccine target. And three, it's critical for virulence. Most non-typable strains are not virulent, so when they lose their capsule, they are not able to overcome the innate host defenses and proceed to disease in normal hosts in general. There are 100 different serotypes, and one of the challenges has been in developing vaccines that target the most important serotypes, but often there's then new serotypes that emerge when we effectively prevent disease due to what we thought to be the most common serotypes. And in general, protection with new vaccines is serotypic. There's some cross protection within serogroups, but in general, it's very specific for the polysaccharide capsule that is in the vaccine. What do I want to talk about today? Why did pneumococcal conjugate vaccines change the story? What's the mechanism for pneumococcal conjugate vaccines to prevent pneumococcal otitis? Direct effects and indirect effects? What's the effectiveness in infants, in children with established recurrent otitis? What's the long-term effectiveness? And what's the importance of replacement serotypes? What's the impact on overall otitis, which is really ultimate the goal? Protecting against only one pathogen in a multi-pathogen disease may or may not have an impact on the overall incidence of disease. What will next generation pneumococcal vaccines bring us? And what are the challenges? And then lastly, a comment about whether the new RSV prevention strategies will impact on otitis. So this study goes back to the 1980s and was the earliest study of pneumococcal polysaccharide vaccine. So this is not the current conjugate vaccine. This is a vaccine that just contains the polysaccharide or the capsule material and is given to children beginning in this setting at 2, 4, 6 months of age. And in this study done by my mentor, Drs. Klein and Teal, they compared an octavalent vaccine, or a vaccine that had 8 polysaccharides in it, which was associated with 8 common serotypes that produce otitis, to a heptavalent or a 7-valent polysaccharide vaccine, but those polysaccharides represented serotypes that were rarely found in otitis. And what did they find? They found a serotype-specific reduction. You can see that 21% of the cases in the heptavalent group, which was more or less the control group, were due to octavalent serotypes, but only 10% of the cases in the experimental group or the octavalent group were due to serotypes within the vaccine. On the other hand, if you look at total number of episodes, you can see they were comparable in both groups. So even though the vaccine to some effect worked, it produced 50% of the episodes were prevented. They only made up a relatively small proportion of the total picture of episodes, and therefore they didn't impact particularly on the overall number of episodes. So it was a success and a failure at the same time. If you break it down a little bit further to age groups, you'll see that in the 5 to 12-month-old age group, there were the same number of episodes and the same proportion of children who had disease in both the octavalent and the heptavalent group. If you look at the older age group, those over 13 months of age, when they were vaccinated, you can see that there's a modest reduction from 64% of the children in the experimental vaccine group compared to 81% of the children in the control vaccine group had an episode. So like I said, overall, the vaccine prevented serotype-specific pneumococcal otitis, but it didn't prevent overall episodes of otitis. A similar study was done in Finland using a 14-valent pneumococcal vaccine given at 2, 4, and 6 months of age. And what they showed is that for certain serotypes, like serotype 6 and serotype 23, which were the most common causes of pneumococcal otitis in their study, there was no difference between the children who received pneumococcal vaccine and the children who received Haemophilus influenza vaccine. On the other hand, for 2 other serotypes, which produced relatively little disease, there were statistically significant differences. There were 14 episodes of serotype or serogroup 19 disease in the control population versus 6 in the pneumococcal vaccine population, and for type 14, it was 6 and 1. And what they concluded was that the reduction in attacks was specific to those pneumococcal types or groups that induced a good serum antibody response, and that very little protection was seen in young infants, those younger than 7 months, or after 6 months after vaccination. And this had to do with the poor immunogenicity of polysaccharide vaccines in infants less than 15 to 24 months of age. And therefore, the vaccine really was not effective in preventing disease in the highest risk groups, the children in the first year or 2 of life. So what happened that changed the story? Somebody figured out that if you conjugate your polysaccharide to a protein antigen, you induce a very different immune response that was successful and immunogenic in young children. And what it shows here is if you polysaccharide alone, you induce B cells to respond, but you don't get any help from T cells, and therefore you get a limited response, and you further apoptose or kill the B cells so that you don't get any memory response either. On the other hand, if you use a conjugate vaccine, you recruit not only the B cells, but the T cells, which provide help and generate a brisk immune response, as well as create memory cells. So by making the polysaccharide vaccine into a polysaccharide conjugate, you enhance the immune response and create memory. And this was a game changer. And this is an example. You see, this uses meningococcal conjugate vaccine versus meningococcal polysaccharide vaccine in children administered vaccine at 0, 1, and 2 months of age. The red line represents the conjugate vaccine. The blue line represents the polysaccharide vaccine. You can see that there's almost no response to the polysaccharide vaccine, but the conjugate vaccine gives you a good response. It then tailors off or decays, and then when you boost them, you get a very brisk response that lasts for a prolonged period of time. And so you change a vaccine that is minimally immunogenic in young infants into a vaccine that is sufficiently immunogenic in the same population. And what are you trying to achieve? Well, the first thing you're trying to achieve is what we call direct protection, where you create antibody that attaches to the surface of the pneumococci that activates the complement deposition and results in opsonophagocytosis and clearance of the pneumococci. And what you can see is that in the absence of antibody, you have the pneumococci outlining on the exterior, of the white cells, whereas in the presence of antibody and complement, the neutrophils engulf the bacteria, opsonophagocytose them, and clear them from the site of infection or the bloodstream. And this was the first randomized controlled trial of a 7-valent pneumococcal conjugate vaccine. It contains the common 7 serotypes listed here that were the most common serotypes causing otitis media. You can see that in the randomized trial, there were 271 episodes of pneumococcal otitis media in those that got pneumococcal vaccine and 400 episodes in those that got the control vaccine, which was hepatitis B. If you look at vaccine serotypes, there were 107 episodes in the vaccine group and 250 episodes in the control group, and the efficacy was 57% against vaccine serotype disease. But you also see the emergence of a potential problem. And what problem is that? You can see that if you look at non-vaccine pneumococcal serotypes, there are 41 episodes in the pneumococcal vaccine group and 84 in the control group. So that you have double the number of episodes in the control group. But if you look at specific serotypes like 6A, it becomes much more common in the children who were in the control group. That's because there's cross protection against some of the serotypes that are in the same serogroup from the vaccine. The challenge was when you look at non-vaccine serotypes and non-cross-reactive serotypes, there's more disease in the vaccine group than there is in the control group. And we call this replacement disease. Similarly, there was more new Haemophilus disease in the vaccine group than there was in the control group, so that this offset some of the benefit. So the overall reduction was only 6% in episodes of overall otitis media. And again, this shows you the curve for the development of otitis media in the group that got control versus the group that got pneumococcal conjugate vaccine. And so we saw one, success against preventing serotype-specific pneumococcal otitis, and two, some modest protection against overall otitis media. Another way of looking at this is a study that took children who were colonized with pneumococci and looked at what was the risk of developing otitis media following being colonized in children that were vaccinated compared to a historical control in children that were not vaccinated. That was called the pre-PCV era, control era versus the PCV13 era. And if you look, you can see on the left side that, for example, serotype 14, which is in PCV7, the risk of developing otitis media in an immunized child is noted by the red dot, and you can see that the risk of developing otitis in the unvaccinated child due to the same serotype after being colonized is much higher. And the right side shows the data for the PCV7 and the PCV13 serotypes, and what it shows is that there's less risk of progressing from colonization to otitis in children that are immunized for most of the PCV7 and PCV13 serotypes. So that's the direct effect, but that's only one way in which the vaccine prevents otitis media. The second way it prevents is by preventing nasopharyngeal acquisition of vaccine serotypes. And obviously, if you don't become colonized, you don't have that bacteria to ascend into your middle ear, and you don't develop otitis media due to that serotype. So there's both direct effect, but there's also the indirect effect that you don't get colonized, you don't spread it to other children within the community, and you don't develop otitis due to those serotypes. So what this shows you is that over time, colonization with pneumococci stays about the same, but you see elimination of the vaccine serotypes from the nasopharynx of children. So again, if you look at 2001, which is following the very early introduction of PCV7, you can see PCV7 serotypes in purple, PCV13 in green, non-vaccine serotypes in red, and missing serotype in blue. Over time, you can see that by the time you get to 2014, which is following the introduction of PCV7, followed by PCV13, that you see there's very few PCV7 serotypes left. There's very few PCV13, and most of the serotypes now in the community are indeed non-vaccine serotypes. So you've eliminated vaccine serotypes from the community. They no longer are exposed to children, and therefore you don't develop otitis due to vaccine serotypes. And this is another way of viewing that. What happens over time is the left-hand heat map shows you the disappearance of the vaccine serotypes, the PCV13 serotypes. First, you see the disappearance of PCV7 serotypes, then the emergence of some of the PCV13 serotypes. Then you introduce PCV13 and you see their disappearance. But you see the emergence of non-vaccine serotypes over the same period of time. So this is called herd effect, and this is a study that I just want to briefly show you that tells you that you need to vaccinate about 65% of the population in order to achieve herd benefit, so that it takes between a year and 2 years following the introduction of a new vaccine before you see herd benefit in the community. And what this shows you is this is the red line are children who are under-immunized. The dotted line are children who are fully immunized. And if you look out about a year and a quarter, when 65% of the children are immunized, you see that the rate of colonization with vaccine serotypes is the same in both immunized and unimmunized children. Where do these serotypes go? A very important question, because some people say, why do you need to keep vaccinating if you've gotten rid of these serotypes? Well, here's a natural experiment from Belgium. They introduced PCV13 in 2016, and then they changed from PCV13 to PCV10, which doesn't have serotype 19A in it. And what they saw is that as soon as they changed over from PCV13 to PCV10, they saw the return of serotype 19A. So what it tells you is that we don't actually get rid of these serotypes from the community, but they are present in very low density in the nasopharynx, too low to really recover by culture. But if you stop immunizing, they return, and therefore they become virulent again. So what I showed you was a slide that said that the rate of colonization in children doesn't really change, but the serotype mix changes. So why does that result in a reduction in disease? And the answer to that is because not all pneumococcal serotypes are the same. And this is one example of how you might measure this. If you look at serotype 19A, the white represents the percent found in the nasopharynx. So at the point this was done in 2010, 19A was found in about 14% among the pneumococci, was about 14% of colonization serotypes, but it was nearly 40% of disease. So it was overrepresented in disease, meaning it was a very virulent serotype. Whereas you look at 23A, which is found in about 9% of children in their nasopharynx, but there's almost no invasive disease, telling you that it's underrepresented in invasive disease because it's a less virulent serotype. And the way in which this is measured is called invasive index or relative invasiveness, and it points out that serotypes can vary in their invasiveness by up to 100-fold. And if you look at the serotypes in the lower range of invasiveness, you see that those are all the serotypes that have emerged in the community in the most recent years following the decay in vaccine serotypes. And if you look at all the ones that are more invasive or more likely to cause disease, you find that they are mostly the vaccine serotypes, which have been eliminated. So changing the mix of serotypes benefits by having lower invasiveness and lower likelihood of colonization progressing to disease. And this is, I'm sorry, the slide is so out of focus, but this is similar, showing that for otitis media, you have a spectrum of likelihood of developing otitis following colonization, and that there's a similar pattern where the vaccine serotypes are more likely to progress and the non-vaccine serotypes are less likely to progress, which is why we have less pneumococcal otitis following the introduction of the vaccine. This slide shows you what has now become the dominant serotype mixture in children with otitis. It comes from the group in Rochester and shows you that the most frequent serotypes are now the serotypes that are not found in either any vaccine, those in the orange, or those in the vaccine that was just introduced, PCV20, which added 7 new serotypes, but has yet to be fully introduced. It's only been in the community for about a year and a half, and therefore we still see some disease due to these 7 serotypes. So in the real world, what happened to otitis media due to pneumococci following the introduction of PCV7 and then PCV13? This is data that comes from Randegan in Israel, and it shows you the near elimination of all the PCV7 serotypes, which are in purple, the gradual elimination of the PCV13 serotypes, which are in gray, and the small expansion in serotypes not in either of those vaccines, which are shown in red. Overall, you see a nice decline in pneumococcal otitis. And indeed, vaccine serotypes have been eliminated nearly completely. And if you look at the pattern over different age groups, now this is a country that uses a 2, 4, 12-month vaccine schedule. And if you look, you can see that, again, in the 6 to 11-month-old group, in the 12 to 23-month-old group, the same patterns exist. The surprise is you can see it in children less than 6 months of age as well. Because remember, they've only had 1 or 2 doses of vaccine, and they've only not yet had their booster dose. So how do we explain that children who are not fully immunized are seeing the same benefit? We see it by herd effect. By removing the PCV7 and PCV13 serotypes from the community, we see the benefit as early as 2 months of age with a decline in vaccine serotype disease. And I think that this is important because disease early in life is among the most critical for either identifying children at high risk or producing some damage, so that many of those children go on to get recurrent otitis media if they get disease early. So we've talked about pneumococcal otitis. What happens with overall otitis? This is a study we did with our group looking at 20 years of experience, and we projected what otitis would be if there were no vaccine, and that's this top dotted line above the light blue area for children less than 5 years of age. And we observed what the real episodes were which is children above the dark blue line, is what we observe. And so you can see there's a reduction from approximately 17 million episodes of otitis media in children under 5 in the United States to something around 12 million episodes of otitis media. And you can see that all groups demonstrate the benefit. Those in red are those between 2 and 4. Those in yellow or orange are those less than a year of age. So all age groups show some reduction in episodes of otitis media. And the same is true in the UK. Here you can see a timeline. It's just called an interrupted timeline series. And you can see the gradual decline in episodes of otitis media per 1,000 person years, from something in the 300 range to something in the 150 to 200 range. So about a 1/3 reduction overall. And you can see that there was a 20% decrease initially during the PCV7 era, and then an additional 6.6% in the PCV13 era. So overall, you see a reduction in otitis as well as a reduction in pneumococcal otitis. I found this study to be very important in the sense of what we discussed about early otitis and the potential for preventing early otitis, and whether that leads to less children developing recurrent otitis media. And so if you look at, again here, these are children who developed otitis media before their 2nd month birthday, and then what happened to them subsequently. And they compared children born in the PCV13 era to children born in the non-vaccine era. And what you can see is that 60% of children born in the non-vaccine era went on to develop recurrent otitis if they had an episode before 2 months of age, compared to only 43% or 44% who went on to develop recurrent otitis if they had been vaccinated as part of the PCV13 era. So again, it shows that we can have an impact on the proportion of children that develop recurrent otitis if we effectively vaccinate them with a pneumococcal vaccine. In addition to preventing acute otitis media, we can prevent recurrent otitis, and we can prevent T-tube insertions in children that have been immunized. And there are now multiple studies that show anywhere from 20 to 35% reductions in tympanostomy tube replacements in children who got pneumococcal vaccine in infancy compared to children who did not get pneumococcal vaccine in infancy. This is a long-term study done by Eric Simoes and his group, looking at children in the Philippines who participated in a clinical randomized trial of the 11-valent pneumococcal conjugate vaccine. And what they showed is that there was a modest benefit in reduction of moderate to severe disease. So that 7.4% of children, in the vaccine group compared to 8.6% of children in the placebo group went on to develop what they're calling moderate to severe disease, which they defined as chronic suppurative otitis, adhesive otitis, or tympanic membrane perforation. They didn't show any benefit on hearing outcomes, but they did on clinical disease outcomes. I'm going to skip this because Peter's going to talk about high-risk groups. This is data from the Alaska Native and Native American Indian group, and again shows the vaccine offers benefit in that group as well. One place where the vaccine has proven to be ineffective is a study that vaccinated children who already had recurrent otitis media. These children were over 1 year of age, and then they followed them, and you can see that there's virtually no difference over the next year to two in the development of more episodes of otitis media. It's not that the vaccine didn't prevent vaccine-type pneumococcal otitis. It's that vaccine-type pneumococcal otitis was such a small proportion of disease in these children who already had recurrent otitis media that there was no observable benefit in this population. So the hypothesis that's been developed, and Ron Degan, myself, Lauren Bakalitz, Robert Cohn wrote a paper about how early otitis leads to middle ear damage, biofilm formation, and results in increased susceptibility to further episodes due to a mixture of bacterial pathogens. And that if you can prevent early episodes of otitis, you can reduce the risk of subsequent episodes of otitis by preventing the damage that occurs following early otitis, especially early pneumococcal otitis. However, if you vaccinate after the child's developed recurrent disease, it's too late because vaccine-type pneumococci are not an important contribution to disease in that population, and therefore you see very limited benefit. The last comments I want to make are about RSV and the introduction of monoclonal antibody for passive immunization in children in high-income countries universally. It's being used in the United States, Western Europe, South America, pretty consistently now. And so you're administering an antibody against RSV that neutralizes RSV. So the first comment I wanted to make was about passive immunization. And there is good evidence that using an animal model for pneumococcal otitis, that if you administer high-level antibody to the animal, that you prevent otitis media. In this case, the animals got passive immunization with something called BPIG, or bacterial polysaccharide immune globulin, which contains antibody to the capsule of pneumococci. They were challenged with 7F, and one of the animals in the BPIG disease, all 12 of the animals in the control group developed disease. The second study was the use of RSV hyperimmune globulin. So RSV hyperimmune globulin was globulin made from whole blood that contained antibodies both against RSV, but also against polysaccharide capsule for both Haemophilus type B and pneumococci. And you can see that there was a reduction from 5 episodes in the group that got high dose RSVIG and 32 episodes in the group that got control infusion or placebo, and this was statistically significant. So again, if you use RSV hyperimmune globulin, you protect it against both RSV disease, but you also protect it against bacterial otitis media. I'm missing a slide here, but I'll tell you the story anyway. The third study was then the use of RSV monoclonal antibody. An RSV monoclonal antibody only contains neutralizing antibody against the F protein of RSV and no antibodies against pneumococci or Haemophilus influenza. And what you saw was a dramatic decline in RSV disease, but no impact on otitis media. And the decline in in RSV disease was limited to lower tract infection and not nasopharyngeal infection with RSV. And that's likely why it had no impact on otitis media, because it still was upper respiratory tract infection due to RSV was not impacted. And now we have nirsevimab, which is a long-acting monoclonal antibody against RSV protein F. It's been being given to infants primarily at birth. And we have seen a reduction in RSV lower respiratory tract disease, and we don't have any data yet on whether it impacts on upper tract disease, therefore whether it will have an impact on otitis media or not. I think the likelihood is that if it has any impact, it will be quite small because it doesn't seem to affect upper respiratory replication and infection with RSV. Lastly, we just introduced a PCV20 vaccine. It was introduced as a non-inferior vaccine immunogenicity-wise, but it has lower immunogenicity than PCV13. And what I'm showing you here is that if you look at the GMC, the geometric mean concentration for each of the types in PCV20, you will see that they are lower than they are in PCV13. And the question about whether or not this reduction is going to be clinically significant or not, we don't know. It met the FDA definition for non-inferiority, but it's obvious if you look at it that they're not equivalent. And we will, over the next year or two, identify whether or not that reduction in immunogenicity is significant or not from a clinical point of view. So I think my last slide, there's the slide that I was missing, and there's my summary, which is PCV creates both direct and indirect protection when sufficient proportion of children have been immunized. That PCV administered in infancy reduces serotype-specific acute otitis. It also decreases overall AOM, insertion of tympanostomy tubes, and development of chronic suppurative otitis, adhesive otitis, or tympanic membrane perforation. It does not prevent further episodes of AOM when administered to children with established recurrent disease. That non-vaccine serotypes of pneumococcus have partial vaccine serotypes, and that next-generation PCV with expanded valency may further reduce AOM, but reduced immunogenicity is a potential challenge, and we don't know how clinically relevant it is as yet. And I'll stop there. Thank you.
Great. Questions from the group? We can allow one question probably. I really like that historical perspective, Steve, how it guides future trials for vaccine development with the study design. It was awesome. And I had a question about whether we're going to need a PCV50, but I suppose based on your last few slides, the jury is out.
Well,
right?
the problem with PCV50 is that it appears every time you expand the valency, you reduce the immunogenicity.
Yeah.
So therefore, we may reach a point where we can't add more and more, and we need a different kind of vaccine. There are different vaccines that don't use conjugate technology that are being evaluated that may be a solution.
Okay. Great. Thank you. I think that's also a great segue to Peter. I'll introduce Peter while he puts up his slides. Thank you again. Peter completed his pediatric training in Melbourne and Darwin, Australia, and since 1994, he has worked as a clinician and researcher in Darwin. So Dr. Peter Morris is interested in trying to understand which interventions can improve child health outcomes in his own clinical practice and globally. He enjoys contributing to clinical trials, systematic reviews, and evidence-based guidelines. Go ahead, Pete.
Thanks, Reggie. It's great to be able to speak today, and thanks for organising this seminar series, and thanks to Landon as well. It's really a great resource. Now, I'm not sure how I'm going to move my slides on. Is there an arrow to move it on, or do I need to go back to my PowerPoint? Oh, hold on. Let's see what happens if I go there.
I think that's better. You have full control.
Yeah, okay, I've got it. Very good. So look, I'm really presenting. I'm a pediatrician, and Reggie asked me to talk a little bit about my background, which I'll do in a moment. But I'm part of a big team in Darwin. And just to disclose, our studies at the moment are all funded by our National Health and Medical Research Council, but we have received funding from pharmaceutical companies that make vaccines in the past. And so there's a potential bias there. In Australia, we traditionally recognise the traditional owners of the country. So in Darwin, we're on what's called Larrakia country, which is their Aboriginal name for this region. And this land was never ceded. And we'd like to acknowledge all the Aboriginal people, their elders, past, present, and emerging. And that's our current Prime Minister when he was visiting Darwin during COVID with some of the members of Larrakia Nation. So today I'm just going to give a bit of my background, provide some tips for early career researchers around identifying some good resources, things similar to Nader's talk about what are some important principles, some opportunities for people now to take advantage of new technology, then the changing field of early childhood immunisation, and Steve's really described very well what a game changer the conjugate pneumococcal vaccine was. And then I'm going to give a couple of examples of studies, trials we've done in the Northern Territory. So a little bit of background. So in 1994, I moved from Melbourne, which has a population of 5.4 million, and it's the very typical, big modern city, to Darwin, which has a population of 150,000. And you can see, so this is the Northern Territory outlined in black, and Australia is a really weird country. So if you can imagine a line going across the middle of Australia, 90% of Australians live in 5 or 6 cities below that line, and only 10% of the population live above the line, and there are no big cities above the line. And you can see the Northern Territory is pretty big. We could fit several, United Kingdoms into the Northern Territory, even though the population of the whole Northern Territory is only 250,000. So we're a small population, and in Australia, about 3% are Aboriginal or Torres Strait Islander Australians, but in the Northern Territory, it's 30%. So we're very different from the rest of Australia. So just some resources for people starting out. And Nader's already talked about this book, Clinical Epidemiology. It's really, for me, I still go back and read it. It's a great resource. The Cochrane Library he mentioned as well. Systematic reviews have been another game changer in how we interpret evidence. And following on from that now, there's a great handbook about how you basically use evidence to produce guidelines and how evidence should be interpreted. Yeah, and then the up-to-date online resource is the first attempt to really be a global textbook of medicine. Always improving, got a way to go, but they're using the grade approach as well, and they're encouraging their authors, who are mainly from the US, to have a global perspective about the conditions they're writing about. And just down here, the Equator Network, if you're interested in any of those trial designs that Nader spoke about, the Equator Network has really good instructions on how you should write a protocol, how you should report your paper. And again, that's well worth knowing about. And then the final resource to mention is just the global burden of disease. And I'm going to talk a bit more about that. Again, based in the US, in Seattle, and making an enormous contribution internationally. And down here on the left, this is from Sackett and colleagues, the original sort of evidence-based medicine pyramid. This is the new version, which is there's less clear distinction between different study types, and systematic reviews and meta-analyses are more a way of looking at the different studies rather than necessarily always being top of the pyramid. So let's start with the global burden of disease. This is what they call a tree map, and they've done it for different regions around the world and every country. And some countries, like the UK, provide data for relatively small regions about what the different burdens of disease are. And if we look at otitis media, this is globally, and it's where they try and measure the total burden of disease in disability adjusted life years. So it's a combination of how many years are lost plus what disability you might get from that condition. And you can see over here, lower respiratory tract infection after the neonate burden of neonatal diseases. Lower respiratory tract infection is second at around 10%. Upper respiratory tract infection is about 1%, and otitis media, the global burden of the total burden, is a little bit less than 0.1%. So it's a very small portion of the. However, it is neglected, and when we first became interested in otitis media, for us, attending the international meeting that this network is attached to was really fantastic. So world experts on otitis media, like Steve Pelton, were at the meeting and were incredibly generous, sharing information. In Australia at that time, in 1994, there was no active, high-quality otitis media research group that we could draw on. So being able to attend the international meeting was very helpful. This is the situation in Australia, and this is what you see in all the rich countries. Sort of neonatal disease becomes relatively more important, and non-infectious diseases also become more important. And actually, the relative importance, although the total burden is less in a rich country, the relative importance of upper respiratory tract infection and otitis media increases. So otitis media now gets to about 0.5%. So still small and neglected. And interestingly, in rich countries, the burden of lower respiratory tract infections is relatively low. So three things I think about in trying to decide what types of research might be useful is research about things that are important, research about things that are neglected, and then research about things that you can do something about. There's some action you can take that will improve the overall situation. So that's really where clinical trials come in. And the results you get from clinical trials, you get a probability estimate of either a categorical outcome, alive or dead, or a continuous outcome like how many days of illness. And that's called the point estimate, but there's a lot of uncertainty. Well, there's some uncertainty always around the point estimate. And it's a bit like all research, I think, can be used for predicting the future, but it's a bit like weather forecasting, where you might say, oh, there's a 40% chance of rain tomorrow, but actually I'm only 10% certain that I'm going to be right. And this is the way the grade group recommends we talk about intervention effects, whether our certainty in the estimate is high, moderate, low, or very low. And basically, the high and moderate estimates are regarded as reliable, and the low and very low estimates are regarded as unreliable. And this is sort of a figure that grade use, and they've published in the Journal of Clinical Epidemiology. I think they're up to about 40 separate different papers now on different aspects of how you should evaluate research. So this is a figure, and it's explaining some of the things that Nader was talking about in trial design. And so they say you need to set up what you think is a small but worthwhile effect threshold, and anything less than that would be regarded as a trivial effect. So in this hypothetical example, they said that you needed to reduce death by more than 1% for it not to be considered trivial. And here someone's done a study, and the point estimate was a 2% reduction, but the confidence intervals crossed the threshold. So it's possible that the benefits might be trivial in terms of death. And that's where you're looking at something as a yes or no question. Does it work or not? More useful, I think, is to break the effect sizes up into groups. So you might have a small effect threshold, a moderate effect threshold, and a large effect threshold. And this is very important for people like us who live in a place with a very small population. Unless we're doing multi-center collaborative studies, our studies are always going to be relatively small, which means that we're only really able to have confidence around detecting very large effects. So in the studies I talk about, you need to be aware there may be smaller effects that we just don't have the capacity to measure. So yeah, that's I think something I've become more interested now is just the need to recognize that uncertainty is everywhere. And even this is something, some evidence from the UK around vaccine hesitancy and what doctors need to do when they talk to people about vaccines who might not want their child to get a vaccine. And certainly if you don't acknowledge uncertainty, actually people are less likely to listen to what you tell them. And scare tactics also tend to be negative. Played out obviously during the COVID pandemic, where vaccines had an incredibly beneficial effect, but did create a lot of controversy in all communities, and even within my own family. We've had lots of fallout from one part of the family who were vaccine resistors. So I just want to go back now, and this is the other very important study around the introduction of the pneumococcal vaccine, and use it as an example of the decision making. So this was the Kaiser Permanente study done in California, that along with the Finnish study Steve mentioned, had a big impact on the decision making about whether to introduce a conjugate vaccine in Australia. So in 2000 and 2001, the vaccine became licensed in Australia, but it wasn't free. You had to pay for it, and it cost about $500 to have a complete course of the vaccine. And this is the data on invasive pneumococcal disease, which was the main focus of this trial, the Californian trial. And you can see the numbers there. The vaccine was incredibly effective, reduced invasive pneumococcal disease by about 90%. But because that's a rare disease, the number needed to treat or to immunize to prevent one case of pneumococcal invasive disease was about 400. So that meant that we had to make a decision whether we felt it was appropriate to pay the equivalent of $200,000 to prevent one episode of invasive pneumococcal disease. And at that time, I was working on a research salary, so I didn't have much money. I had two young children, so I had to make the decision for them. And I decided it wasn't worth the money, so I didn't actually pay for the vaccine. Interestingly, I've recently presented this to my colleagues and they've all told me I was crazy. There was no one else in the room who wasn't willing to pay $500 to get the pneumococcal vaccine. But there's an interesting story about what happened in Australia, which if we have time later, we can talk about. But anyway, as a result of that study, the pharmaceutical companies became very interested in the impact on otitis media. And Steve's talked about there was a modest impact and sort of 6 to 8% on episodes of acute otitis media. But they estimated that actually the economic value of that very small difference in the rates of otitis media, the economic benefits were actually greater than the benefits from invasive pneumococcal disease. And so there became a real interest in otitis media. And in Australia, otitis media was something that people just weren't that interested in prior to this. And this is what happened in Australia. And they did introduce the vaccine, and actually the Northern Territory government paid for it out of their own funds so it could be available in the Northern Territory for Aboriginal children as soon as it was licensed. But the rest of the country got it in around about 2004. And you can see very dramatic improvements in invasive disease. Now you'll see here the rates of invasive disease were 50 to 60 per 100,000. This is in under 5 children in Australia. In the Northern Territory, from data from the late 1980s, early 1990s, the rate of invasive disease in Aboriginal children in the Alice Springs area was 2,000 per 100,000. So it was 20 times higher than the rates of non-Aboriginal children. So whereas I thought that it was a relatively expensive vaccine for my children, it was very good value for Aboriginal children living in the Northern Territory. So as part of that talk, I was giving out our trainees and consultants. One of our senior trainees sent me a text back when I said the title was, are there any benefits of immunisation for otitis media? He said, ChatGPT says yes. And the interesting question is, okay, maybe that's true, but can we get a little bit more granular, like how big is the difference? What's the probability that difference is likely to be a true difference? And then is that difference enough to support an immunisation program just targeted at otitis media? And one of the things that it made me think about is for early career researchers that new technology around artificial intelligence is another game changer. And I don't know much about it, but you really need to look at how you might be able to use it to benefit your own research program. And I think particularly if you're knowledgeable about a topic, it's really good to look at where it's unreliable, because it's not always reliable. It's very quick, but you need to be careful. So if we're interested in pneumococcal vaccine, one of the things, and the perplexity, which is the current AI option I like, because it's perplexity works more as a search engine. So it's a sophisticated search engine. And so it's providing you with references that you can look at very quickly, which is what I'm using it for at the moment. But anyway, these are the trials. The Cochrane review doesn't include the latest Filipino trial yet, but hopefully it will soon. And the key information in a Cochrane review is in their summary of findings table, and this is just pasted out of that, and you can see the two trials that looked at the 7-valent pneumococcal conjugate vaccine, found a relative risk reduction or vaccine efficacy of 6%, which meant a number needed to vaccinate or treat of 10. Now I'm going to come back to this other information, basically from a single trial of what was then an 11-valent conjugate vaccine from the Czech Republic, where they found a much bigger vaccine efficacy, but actually because the rates of the outcome were much less, the number needed to vaccinate was actually almost twice as many to prevent one episode of acute otitis media in that trial. And I'm going to come back to that trial again a bit later, because that was very relevant to us in the Northern Territory. And the other vaccine that is potentially important for acute otitis media in all populations is the influenza vaccine. And there've been quite a few studies, but they're very heterogeneous. I mean, influenza must be one of the hardest infections to vaccinate against, because the types of influenza that are causing disease can vary each year. The timing, although it's usually a winter peak, it's not always a winter peak. And we saw, like during COVID, when behaviors change, actually the timing of the peaks of viral infections can also change. But anyway, in the short term, it does look like if you give young children influenza vaccine, you get some protection against acute otitis media, with a number needed to immunize of about 20. But just be aware, you have to know when the peak is coming, and you have to give the vaccine before the peak. And then this is looking at the benefits over the sort of the influenza season. So it's not like the pneumococcal vaccine, where potentially you get very long-term benefits that keep compounding over time. So this is an example of where you need to be careful with artificial intelligence. So I was getting it to do the work for me. It couldn't remember the exact results from the Cochrane review. So I said, oh, can you just quickly give me a table with the actual numbers from the Cochrane review from the summary of findings table? And it did a nice table. And actually the risk difference here, this is correct. And the quality of evidence is correct down here. But these numbers here are made up. And in fact, if you try and work out what the relative risk is from these numbers, you don't get this result. This is the true result from the review, but it doesn't match the numbers they've given me when I asked for the actual data. So I think it's going to save people a lot of time, but you're going to get caught out if you don't check the data carefully. So this is another, and Nader's group has done an incredible amount of work around the accuracy of diagnosis, which is critical. So and look, the global burden of disease, they're doing their best to make estimates, but they're limited by the quality of the data that's available to them to make the estimates. And they're just generally being informed by the types of studies that groups like ours are doing. So what's the global AOM incidence in children less than 5 years of age? And they estimate it's about 5% of children, so 5 per 100 will get an episode of acute otitis media each year. In Australia, they've come up with an estimate of 1 to 5%. Interestingly, in the USA, the estimate is somewhere around 60%. So why is it that the USA have rates of otitis media 10 times the rates in Australia? And I think that must be related to diagnostic methods, because most Australian cities are very similar to US cities. And then in India, again, they've come up with an estimate higher than Australia, but it's interesting to drill down and just have a look at why they've come up with that estimate. Now, just to sort of mention, although this US rate seems to be high, it's actually not that high. So in the pneumococcal vaccine trials, where they monitored very carefully for episodes of acute otitis media, in the first Finnish trial that Steve talked about, and then the Kaiser Permanente trial from California, the rates of acute otitis media in the younger children, so they were under 2 years of age, but it was more than 1 episode per child. So in the US study, it was about 1.6 episodes per child, and I think in the Finnish trial, it was about 1.2 episodes. So if you look for acute otitis media and you use a reliable diagnostic approach, I think the actual rates may be quite different from the estimates from the Global Burden of Disease study. So now just to turn to the Northern Territory research. So when I arrived in Darwin, this is John Matthews, who was my PhD supervisor, and he was an epidemiologist. He was a bit ahead of his time in that he was very interested in both epidemiology and understanding the biology, and he got very early on, he got into mathematical modeling of infectious diseases and was applying that to things like otitis media in the Northern Territory. Amanda Leach runs our otitis media research program, and she's the lead investigator on most of the vaccine studies. Heidi Smith-Vaughan was working in the lab, and she did her PhD on non-typable Haemophilus. And it was Amanda and Heidi and I who went to the meeting in 1995 of the International Symposium of Otitis Media. And that's where we really started to learn about the, what were the drivers of otitis media and how you measured it and things like that. And then a couple of younger researchers, Robin Marsh, who is online, who is leading the area of looking at the molecular level of infection in Northern Territory Aboriginal children. Jamal Bath and Michael Binks are both involved in our newer vaccine trials. So the key study for us in the Northern Territory and how we think about otitis media was published in 1994, and it was work done before I came to Menzies, and it was the people doing most of the work were Amanda Leach and Judith Boswell. This is Judith Boswell. She was an audiologist who died sadly relatively young from breast cancer. But this was her PhD was the clinical aspects of otitis media in Aboriginal children. and Amanda's PhD was around the microbiological aspects. And this is the key piece of information. And this was a very small study. It was about 40 Aboriginal babies born on the Tiwi Islands and about 20 non-Aboriginal babies born in Darwin. And they were all followed very intensively for the first year of life. And it really, it was the first time to document that the organisms that caused otitis media in Aboriginal children were the same as the organisms that were causing it in other countries, and that studies from the US and Europe had documented very well. But up until then, people thought, for example, otitis media in Aboriginal children was related to chlamydia because we have very high rates of trachoma. And some of the studies hadn't been able to isolate pneumococci or Haemophilus, which was probably related to the laboratory's capacity to do that. Anyway, the important message from this study was that in these Tiwi infants, they were nearly all had otitis media by 3 months of age, and they were virtually all colonized with multiple types of pneumococcus, non-typable Haemophilus, and Moraxella. And this is really interesting because, of course, the traditional model of otitis media is that you get a viral infection first, and then if you happen to be colonized with pneumococcus or Haemophilus, that can spread to the middle ear and cause acute otitis media. But the fact that all the babies were getting it not related to circulating viruses within the first few weeks of life suggests that in high-risk populations, something else might be going on. And again, we agree with Steve's hypothesis that we think multiple organisms and the inflammation that results in is a bad thing. So just a little bit more context for people interested in Aboriginal child health. The history is relatively recent. So Aboriginal Australians weren't recognised until 1967. So that was the year that, so still less than 60 years ago, that was the year that they were allowed to vote. So prior to them, they were not recognised as Australian citizens. And in fact, this is a photograph of the last group of Aboriginal nomads who came out of the desert in 1984. So they were living nomadically in the desert, and the father figure of this clan group had died, and so they went to find other clan groups because they weren't able to continue living completely independently. And the respiratory presentation, when I first came to Darwin, it was known as the respiratory triad. So it was this combination of having a chronic runny nose, a chronic wet cough, and chronic discharging ears. And so lots of children would have all three of those conditions. So they would be often otherwise healthy, running around and playing, but they had a chronic bacterial mucosal infection. And again, otitis media is confusing, but runny nose is even more confusing, as Nader talked about with sinusitis. When do you say, oh, it's just a runny nose, and when do you say, oh, actually, no, it's persistent sinusitis and might benefit from antibiotics? So we've got another research group interested in a condition called protracted bacterial bronchitis that Robin does a lot of work on. And the woman who comes here, Anne Chang, is from Brisbane, and she's a world expert. And she's actually, if you are interested in other mucosal infections related to otitis media, she's written the chapter in Up to Date on protracted bacterial bronchitis and chronic cough. So this is Nader's recent article on otitis media in young children. And again, it's a really good starting point for understanding the current situation. And I really like it's got a a very realistic case scenario, excellent videos. And again, video otoscopy has been a game changer for us because we never really knew what we were looking at when we started our research program. But the Pittsburgh then had a training diagnostic training program online that, well, originally we bought the videos, the training videos, and then it was available online. And that was a fantastic resource for us. And certainly people may not be aware, but there was a lot of confusion around how you diagnosed acute otitis media. And in fact, the Pittsburgh recommendation that bulging is by far the most important feature has proved very true for us. Children with a tympanic membrane asymptomatic, but if is a paper I hadn't seen that was referenced in Nader's review. It's the current situation from Japan, and I think this is realistic of probably all rich countries. So if you can find studies that have used tympanocentesis, you definitely should take advantage of them. And what you can see is when you culture the fluid from acute otitis media, Haemophilus, non-typable Haemophilus is now the most important organism, but pneumococcus is still second, despite the vaccine. And if you then go on to do PCR studies, you can see that actually most infections involve either pneumococcus or Haemophilus, or actually often both, that you might not get from culture. And as Nader highlighted in his review, it's very unusual to get a simple viral infection causing acute otitis media. There's nearly always the bacteria involved. And this is the actual data from that study, again, just showing that it's still in rich countries dominated by Haemophilus and pneumococcus. So this is the first study that we did that I wanted to talk about. So this was a randomized controlled trial of maternal immunization. So we'd identified that the first few months of life were most important, but we were aware that if you immunized mothers, the antibodies transferred to the babies could be protective. So this is a relatively small study for a vaccine study, only 227 women randomized, and they got either the 23 polysaccharide vaccine during pregnancy, or they got it after birth. This is the mothers to see if there was any benefit through transfer of milk, or they didn't get vaccinated. And this is probably the most important slide from the paper. And again, you can see it was in the post 7-valent vaccine era. So a lot of the 23 types are already less common than the non-23 types, because several of these are also in the 7-valent vaccine. And you can see the trend was in the right direction, but it wasn't statistically significant in that the carriage of pneumococci was generally less in the women who got vaccinated during pregnancy. The lead investigator on this study was Ross Andrews, and he has been very important in Australia in rolling out influenza vaccine for pregnant women and also pertussis vaccine. But this at that time was a bit of a proof of concept. Would women accept maternal vaccination? So this was the study I mentioned earlier from the Czech Republic. which we were very excited about. So it was the study that had by far the biggest impact on outcomes. So about a 50% vaccine efficacy for vaccine type pneumococcus, but it also had a 30% vaccine efficacy for non-typable Haemophilus. And that's the rationale was it was because the protein conjugate was the protein D from the non-typable Haemophilus, and that was providing protection against Haemophilus infections. Now, one thing again, you have to, whenever you see these studies that seem very different, you have to really look closely at the methods. And this was done in the Czech Republic and Slovakia. And actually, in this trial, the pediatricians had to identify a child as having acute otitis media. They were then sent to an ENT surgeon who did the tympanocentesis. And the rates of infection using that approach were exceedingly low, much lower than in the Finnish trial where they also did tympanocentesis. Anyway, as a result of that, Amanda was just thinking about, well, how can we look at the impact of this new vaccine? And the difficulty was around the time she was starting the study, 2011, Australia had just switched from the 7-valent conjugate vaccine to the 13-valent. So she was in her study looking at the impact of the standard approach, which was the 13-valent conjugate vaccine, versus an alternative approach, which was so it had become a 10-valent conjugate vaccine, the VIII-CV, so conjugated to the non-typable Haemophilus protein, and versus a third group that got 3 doses of the Haemophilus conjugate vaccine with a standard 13-valent booster. So there were the 3 groups, again, a relatively small study for a vaccine study, but intensive follow-up looking at both colonization and otitis media as outcomes, with the primary outcome being the clinical outcome of otitis media. And again, the take-home message is the 3 different approaches, sadly, only at best, there were only trivial differences in rates of otitis media. The only important positive message to come out of this study was actually over time, and it's unclear how much pneumococcal vaccine contributed to this, but there had been an improvement overall in babies living in remote communities. So whereas still most babies were being affected by otitis media, it was now taking around 6 months before you were seeing that, whereas before it was about 3 months. So still bad, but some improvement. And then again, here's just again looking at another way at looking at the any otitis media. And then these are the different forms of otitis media. Prior to the pneumococcal vaccine, about 24% of children under 2.5 would have eardrum perforations at any point in time. And we did a follow-up study after that, and actually there was a very slight reduction that wasn't statistically significant. So it went from 24% to 21%. The good news is now in this study, the rates are sort of between 6 and 10%. But still, 75% of infants have persistent or recurrent otitis media, and there's only 1% of these 400, so only very handful of children normal is for at least 3 months. Things are improving, but they're still terrible. And again, here microbiology, incredible rates of colonization, but it's not all children with all types. by 3 months. So again, it's taking 6 to 12 months. Moraxella is now the most common colonizer, and pneumococcus and Haemophilus are still very prevalent, but much less than they used to be. And as Steve says, colonization is the key. So that is a positive. And we have a specific serotype in the Northern Territory, 16F, which is a persistent problem, and it's not in most of the conjugate vaccines. And 16F does cause invasive disease and does have reasonably high rates of antibiotic resistance as well. And again, I'm getting to the end now, but there is a new vaccine that's been designed as an alternative for adults who are already vaccinated with the conjugate vaccine. So it's a new conjugate vaccine that includes lots of types that aren't included in the standard extended PCV vaccines. And we're excited because this vaccine also includes 16F. So at the moment, our group are thinking about whether there's a role for this vaccine in maternal immunization. So we'd like to do a study looking at the potential benefits of maternal vaccination with this vaccine. And then also Aboriginal children get a 3+1 course of the PCV13 at the moment. We haven't gone to the 20-valent yet. But they also get a booster with the 23-valent at 4 years of age. So it may be that this is a better option for the booster vaccine. So in conclusion, I think using artificial intelligence, I think will make research more efficient for people who are doing summarizing all the available evidence. However, I think you can't take what you get at face value. For our high-risk population, and other populations might be different, but it looks like vaccination probably has a positive but modest impact on otitis media. But we don't have any alternatives that are any better. So we see the same very modest effects of antibiotics as well. Colonization is important, and I do think we're at a pretty exciting phase for research and implementation. And in Australia, we've got now nationally a lot of people interested in otitis media and Aboriginal children. I see, I don't know if she's still online, but Jackie was online earlier as well, who's in Adelaide running their program. But most of the interest is in implementation research. So how do you use the information you get from the more basic studies and the clinical trials to actually apply it in practice? And a specific otitis media vaccine, which there are groups been working on for years and years. So some combination of pneumococcus, Haemophilus, and Moraxella that's active for otitis media and also for bronchitis in adults would be a great innovation, but I think it's probably still some time away. So I'll finish there and just think we've been very lucky in Darwin. We've had a lot of families who have supported our research for more than 30 years, and we're very grateful to them. So I might see if I can stop sharing. Thank you very much.
All right. Tanya says congratulations to all three speakers. This is a really important webinar for the otitis media community, and Landon and our job is to spread the word that this webinar will be posted. So I will allow one burning question or discussion point among our speakers if there's somebody who wants to raise anything.
I think the question I would ask you, Peter, is how do you distinguish how it advances in social conditions versus success vaccine trials impact on the disease burden?
Yeah, if I knew the answer to that question, Steve, I'd be world famous. So I don't know. I think we think of severe otitis media with perforations as a disease of poverty. So I would bet on its improvement in the social determinants. But the families are still incredibly poor. So the median family income in the remote communities is about 500 Australian dollars a week, so about 350 US a week for a family. So very different from other families in the Northern Territory and other families around Australia. So I think it's probably related to poverty, but the vaccines are helping as well. And the good thing about the vaccines that is hard to measure, like you talked about the indirect effect, no one knew how big the impact of immunizing babies was going to be on the health of elderly adults for pneumococcal disease. That was amazing. We hadn't predicted that. Maybe other people had, but we certainly hadn't in Australia. And the good thing about vaccines is the benefits compound over time. You can give a short course, and each year you're getting additional benefits that might be too small to see in a single year, but over 10 or 20 years could be quite substantial.
Peter, that was a great talk. I love hearing your stories. And I think we all have the same goal, which is really to prevent the complex outcomes. It may be that the cost benefits look at single episodes, but we know that the real impact on child health is on children who have complex disease.
Thanks, Steve.
And with that, we will close this session. Thanks, everyone. Hope to see you in November for the next webinar.
Everybody have a good week.
Thanks, Reggie. Thanks, Lyndon.
Thank you. This is really great.